Over the last few years, there's been a huge development in the treatment of CLL, and we've got therapies that really have had a major impact on the outcome for patients. And what's now changing is to move these therapies into a more time-limited rather than a continuous treatment. And so and if we're going to stop therapies such as ibrutinib and venetoclax or combinations, then it's going to be, I believe, important to eradicate detectable disease so that patients will be able to have a prolonged period of time off treatment, or even potentially indefinitely off treatment, before the disease potentially comes back. So we're using MRD now as a tool to define the duration of therapy in patients. I think one of the debates at the moment in CLL is are we going to use the novel targeted treatments indefinitely, or are we going to use them for a fixed duration of time? And then if we use them for a fixed duration of time, which I think will be probably an approach that will be taken in front line, is that going to be a fixed duration regardless of response, as we're seeing in Murano and one or two other trials, whether it be a year or 2 years of combination and stopping treatment, or is it going to be defined by assessment of response using an assessment of minimal residual disease, which I believe is the way forward, really, because some patients will respond more quickly and will have deeper remissions to a shorter duration of therapy, and so we'll probably need a shorter duration of treatment than someone who's a slower responder. So that's how we're using it in our trials.